The following is a production of Texas Lutheran University. For more information, please visit tlu.edu.
Well, good afternoon, everyone. I want to welcome everyone to today's Biology Department seminar. We're very fortunate to have a local cardiologist, medical doctor, as our guest speaker today. And I want to introduce Dr. Ronnie Garcia to you. He's standing to my right. Just as a way of introduction, Dr. Garcia is a native of San Antonio. He is a graduate of Our Lady of the Lake University in San Antonio also, and then went to medical school at the University of Texas Health Science Center School of Medicine in San Antonio. He was in the Navy after graduation and completed an internal medicine residency at Naval Hospital Portsmouth and served as a Navy internist for 2 years in Corpus Christi, and then completed a cardiology fellowship in 2006 at National Naval Medical Center in Bethesda, Maryland. Dr. Garcia is a general cardiologist with a special interest in non-invasive imaging modalities to include the latest advancements in coronary angiography. And he may talk about some of this in a moment. His bio on his practices, a brochure says he's a strong advocate of preventative cardiology and early treatment, and I can attest to that. He is, in fact, my cardiologist, and so I'm very pleased to have him standing here on the podium. So please welcome Dr. Ronnie Garcia to our talk today.
Thank you.
Dr. Garcia will be talking about evaluation of a patient with chest pain.
So, I guess everyone here is, I guess, science majors or thinking about science majors. So I was in the same place many years ago. One of the things I love, before I actually get talking about, evaluating a patient with chest pain, is just sort of giving you an idea. I guess when I first started, when I was in college and I was thinking about going into medicine, no one in my family was a physician, and so I didn't really have a clear understanding exactly what it was, the long process of going on to, it just doesn't end once you finish medical school. That's really just sort of the path of going on to a new profession. It's a very long process, 4 years in college, then very competitive to get into medical school, and then once you're in medical school, it's a full-time job. Classes, when I was there, classes started between 8 and 9 in the morning, and they went till about 3 to 5 in the afternoon. And then usually you'd go home, rest, eat something, and then you'd study most of the night. And that was a process for 2 years. And then after 2 years of classes, then you sort of went into your clinical rotations in the hospital. And then at that time, it was just 12 to 15-hour days in the hospital working, and weekends included. And the crazy thing is you're actually paying to work, so it's a little different. When you finish medical school, then you head on to residency, and you sort of choose your residency based on what you think you want to do and what type of medicine you want to practice. And for me, I always knew I wanted to do cardiology, so that meant going into internal medicine, which is 3 years of training in internal medicine before you even get to cardiology. And then once you're into cardiology, it's 3 years of training in cardiology. Even after that, there's even subspecialty in cardiology. If you want to do invasive cardiology, it's an additional year on top of that. If you want to specialize in abnormal rhythms of the heart, that's an additional 2 years on top of the cardiology. So it's a long time of training. And the good thing is it's sort of getting a little better. They now have it if you're a resident or a fellow and you're in training. They limited the amount of work that you're doing to, you can only work 80 hours in a week. You're not supposed to work any more than 80 hours. And that still seems like a lot, 80 hours in a week, but normally before they impose those type of limits, most residents were working well over 100 hours a week. And you would go, 24, 36 hours with no sleep at the hospital seeing patients. Then you'd go home, get your 8 hours of sleep, and then you'd be back the next morning doing the same thing. So It's a very tough process to get through, but it's very rewarding. Taking care of patients, getting to know them, know their families is fantastic. I love it. The other thing that I never realized when I was starting off going into this career was that even after finishing all that training, it doesn't end. You constantly have to keep up with reading about the newest technology, newest medications, new procedures, and that's very time consuming too, because you're working, 10, 12 hours a day, and then you have to keep up on everything. And nowadays, with all the information available on the internet, you really have to keep up on everything, because the last thing you want is for your patient to come in and say, hey, I saw something on the internet about this new medication coming out, and you're scratching your head going, well, I'm not sure about that. So you really have to be on top of your game. So the training or the knowledge you need in this field is just constantly, it's a work in process. Even most of the medical boards require that you do so many hours of training additionally every year. And then every 10 years, you have to recertify. So it's not like I think a lawyer, you sit down for your board exam and you pass it and you become a lawyer. In medicine, every 10 years, you have to take recertify, showing that you have kept up with cardiology knowledge and you're up to the latest standards in practice. So it's a pretty big deal. Every 10 years, you have to restudy for a 8-hour test. And if you don't pass it, well, then you're no longer credentialed and you can't see patients. So it's a really big deal. The process just doesn't end with the school. It's a continual education of a lifetime in medicine. And so if you guys are really thinking about that, be prepared for that, because when I was in college and I was thinking I really wanted to do medicine, and I was very interested in it, but I really had no idea that it didn't stop after the training. It just continues on. It's just nonstop, which is nice in some ways because you're up to date on everything and it keeps you active. But at times it just becomes overwhelming, just like anything else can be. And so just wanted to throw that out there, that if you're thinking about going into medicine, just if you don't have someone in the family that you can see how it impacts the life of that person. Just wanted to give you an idea of it's long hours, but it's very, very rewarding. Today I was going to talk about just evaluation of a patient with chest pain. As a cardiologist, that's probably the number one thing that I get called for, is someone in the emergency room or someone coming into the office saying, I've been having chest pain. And as of right now, statistically, cardiovascular disease, heart attacks, stroke is still the number one cause of death in adult Americans. You can add up all the cancers and they still do not come up to what heart disease is. So people get very worried when they start to have chest pain. It's a very frightening thing. And so that's what I'm going to talk about, because it's the most common thing, and you have to put a little bit of thought into what you're going to do with these patients, because not every patient is the same, and it depends on certain things. So approach for it is, you want to assess the acuity of the presentation. So if someone walks in and they're sort of, they look fantastic, they look healthy, and they're telling you they're having really bad chest pain, but they look very comfortable, the acuity may not be that high. If you're in the emergency room and you see someone and they're very short of breath, trying to catch their breath, and when they're talking to you, they're just sort of struggling, they look a little pale, the acuity is different. So that's the first thing you do, is you sort of eyeball the patient and try to determine, well, how bad is this? So I think that's one of the things we look at. And probably the biggest thing we do when a patient comes in with chest pain is we try to figure out what their pre-test probability of disease is. So it's different on every patient depending on multiple factors, and I'll sort of go into those factors. But I look at the patient when they come in with chest pain and I try to determine what are the chances this patient has got coronary disease or heart disease that is causing their chest pain. Clearly, not every patient that comes in with chest pain has got heart problems. It can be from all other kinds of etiologies. You can have inflammation of the ribs and sternum. We've seen people with pinched nerves, folks with muscle spasms and sprains. There's all other different kinds of things. Acid reflux, there's all kinds of different things that can cause chest pain. And so you have to look at the patient and you have to determine what their pretest probability is. And based on what their probability of having disease determines how you're going to prove that they do or don't have disease, or how are you going to treat them immediately. And so that's probably the biggest thing that we look at. And that helps determine, the appropriate testing. Testing, when we see a patient, can go the whole gamut. I can see a patient and say, look, I don't think this is your heart. I think this is something else. We don't really need to do any test at all other than maybe an EKG. Where there are other patients where I see and I say, we need to go straight to doing a cardiac cath. We need to get in there and take a look at the arteries to the heart, immediately. So we can go from doing nothing to going straight to doing invasive procedures. So your pretest probability helps you with that. And then disposition, what are you going to do with the patient? Do they need to be admitted? Can they go home? Do they need a referral to the GI doctor for their acid reflux? You have to look at all these things. And so one of the first things we do after we sort of just look at the patient and get a feeling of what kind of distress they're in is we get a history, and we sort of want to try to find out about their chest pain. These are some of the things that I always look at: the character, intensity, how long does it last, has it been progressing, is it associated with exertion, can I reproduce it, any previous episodes, what is their current level of activity. So there's a lot of things that I look at, and I really try to push the patients in answering these questions. Well, what does it feel like? Is it a sharp stabbing pain? Is it a pressure or tightness? Folks that have true heart disease will tell you, if you ask them, are you having any chest pain, or tell me about your chest pain, they'll immediately correct you and tell you, I've never had chest pain. It's not pain. It's a tightness. It's a pressure. They'll clearly tell you, I've never had pain, and then they'll describe, it just feels like there's someone standing on my chest, it's just tight. So, you ask for these things, is it sharp stabbing? Does it radiate? Does it go up into the neck, down the arm? How long does it last? If someone has a pain that's, right over their heart and it lasts 1 second or 2 seconds and it's gone, and then it comes back again, a couple hours later, that's not really typical of heart disease. Usually when someone has heart disease, it's sort of a gradual process. The tightness or pressure sort of builds, peaks, stays there for a couple of minutes, and then as the patient sort of either relaxes or stops activity, the pressure starts to fade away. And so the pattern of their pain can help you too as well. And then, we look at, is it associated with anything? Is it associated with exertion? Patients come in and say, well, I can get it when I'm just looking at TV. And then you ask them, well, what kind of work do you do? Well, I work outside. I work at the steel factory, and I'm going up and down flights of stairs. Well, do you ever get any symptoms when you're exerting yourself going up and down stairs? No, nothing. I only get it at night when I'm at the dinner table or, I'm looking at TV. So is it associated with the exertion or not? That's usually a very good sign, and that's something that we press patients on. And then if it's reproducible, that's a very big deal. So if someone comes in with chest pain, and normally if you can touch on their chest and it causes the exact same pain that they're coming in to see you, that's normally that's not your heart. Your heart being a vital organ like your lungs and your brain is really encompassed in bone. So you can hit your chest and you don't damage your heart, just like you can knock on your head and you don't damage your brain. So pushing on your chest should not cause you to have heart pain. If you can push on your chest and you reproduce symptoms, that's almost always going to be from muscle or skeleton or bone. That's not going to be from internal. We're designed pretty smartly in that aspect. And then, we look at other things, has the patient ever had a history of heart disease before? Well, we know once you've had heart disease once, the chance of having recurrent disease is much higher. So if someone said, hey, 5 years ago I had a heart attack and this is sort of the same type of pain that I had 5 years ago, well, that changes how you may treat the patient. And then level of regular activity, how much are they doing? And that's what we ask about, whether it's exertional or not, and what type of activities they do at home. It gives you a better idea. And then these are some of the risk factors that we look at. So after we get a history and trying to figure out whether this is, from the history we try to determine whether their symptoms sound like it's non-cardiac, it's coming from something else. likely cardiac or clearly it's cardiac or coronary. Once we determine that from the history, then we sort of look at the risk factors. Have they ever had heart disease before? Are they diabetic? Do they have peripheral arterial disease, meaning do they have blocked arteries in other parts of the heart? Very common things is blocked arteries in the neck and blocked arteries in the legs. If you've had blocked arteries in any of those two areas, in those two vascular beds, you have a 70% chance of having coronary disease right off. It's the same risk factors that cause disease in your legs or in your neck are the same risk factors that are going to cause a disease within your heart. The arteries in different parts of the body, they're the same. So you can block an artery in your neck, you can clearly do it in your heart. The three most common places are neck, heart, and legs. And so, if someone's had a history of peripheral arterial disease, that's really a red flag that, they could have coronary disease. And then some of the more traditional things that we look at is do they have a history of high blood pressure, high cholesterol, dyslipidemia, tobacco use, a family history of heart disease, and this becomes a little more complicated with the family history. It's more strongly associated in immediate family. So if your parents have had heart disease or your siblings, now if you've had a couple of aunts or uncles or your grandparents, the relationship falls off. So it's really an immediate family. So if everyone in the immediate family hasn't had heart disease, that's not really a risk factor as much. So that's something you have to look at. And then we look at their lifestyle. And then nowadays we look at obesity I have listed on here, but obesity in of itself is not a risk factor for heart disease. The fact is that obesity predisposes you to other things on this list. It increases your risk for diabetes, increases your risk for hypertension, high blood pressure, increases your cholesterol. So diabetes is not an actual risk factor. It just predisposes you to having some other illnesses, which then are considered risk factors. And so as you can imagine, as we see a patient and we're looking and going over their medical history, well, the more of these risk factors you have, the higher the probability that you're going to have heart disease. And so we sort of have to add those up. Now, we also have to take into consideration things like folks that have had diabetes for a long time, they get nerve damage and they get neuropathy, meaning that they start to lose feeling in their toes and their hands, and they don't perceive hot and cold and even painful stimulation the same way as a non-diabetic does. And in diabetics, some diabetics have heart disease and they have no symptoms at all. Diabetics are prone to getting things that we've all heard of called silent heart attacks. They can have a heart attack and they just feel like for a couple of days they feel tired and fatigued, and don't want to get out of bed, and it turns out that they had a heart attack. They had no chest discomfort at all. So diabetics are a whole different class of patients, but as you add up these, your chance or your probability is higher. That helps determine what you're going to do with these patients. And then, we do a physical exam. It does play a very important part in seeing a patient. A lot of the way we figure out what we're going to do with the patient is based really on a good history. A good history, talking to the patient, can help you out just as much as doing a physical exam. A physical exam does have its place, but you have to talk to the patient. You can get just as much information by talking to the patient and asking them questions and listening to their responses. That's just as good as ordering tests or immediately going to take a listen to the patient and doing a physical exam. And sometimes that gets skipped. But things that we look at is their heart fast. Are they tachycardic? Their blood pressure, is it high or low? These things, new S3 or S4 are specific heart sounds that when we listen to the heart, it's an extra beat within the heart. Usually it's just a two-sound beat with the heart. It's a S1 and a S3 is how we call it. But sometimes you'll get an extra beat in there that we call a gallop. And that extra beat, anytime you have one of these extra beats, they're pathological. You shouldn't hear those. So if someone has an S3, that usually implies they probably have a little bit of heart failure. And if someone has heart failure, then that normally means they have heart disease. Other things we listen to are new heart murmurs. If you have a patient that you've seen before and you've listened to and they don't have any heart murmur and now they have a new one, you have to ask yourself, well, why is the heart not functioning normal anymore? Why is the valve leaking? Sometimes the valve starts to leak is because it's been damaged because it's not getting enough oxygen or blood flow to that valve, and so you'll get a new murmur. So listening to the patient does help. And, of course, it's nice if you've seen the patient before and you can, sort of in your mind or look over your old notes, determine whether they had the murmur before or not. And then you listen to their lungs. Do their lungs sound clear? They're moving air in and out. Folks that are having a heart attack or have had one, a lot of times will have fluid build up in their lungs. And you'll hear people say that, someone in the family got admitted and they had fluid in their lungs. And that's what we listen for. You can clearly hear it. It usually starts at the bottom of the lungs and works its way up. But when you listen to someone, you can hear it. It sounds like Velcro. When you pull Velcro open, it's like a crackling sound. And you'll hear that in the bases of the lungs. And that's usually a sign that fluid is building up. And so that's one of the things that we look at. And then when we listen to them, we listen to see whether their heart is in a nice regular rhythm. Usually if someone has got an irregular heart rhythm or are in an arrhythmia, the chances are it's because their heart's been irritated for some reason. Your heart just doesn't, in most instances, doesn't just flip into a new rhythm. It's usually irritated by something. And if you're seeing a patient that's complaining of chest pain, it's likely if they're in a new rhythm or they're having an arrhythmia or an irregular heartbeat, it could be because of poor blood flow to the heart is triggering these type of irregular beats. And then additional things that we do, and this is what happens a lot of times is, especially in the emergency room, when we get called to see a patient, the first thing we do, and I'm guilty of it, is I want to see his EKG, because the EKG really does help you out a lot. And so sometimes you can jump the gun. Instead of going straight in to talk to the patient, you want to say, well, what does the EKG show? And it's fantastic because sometimes you might have an old EKG to compare it to and have a reference or a base point. Sometimes your EKG doesn't help you at all. If someone has had a heart attack in the past and they're coming back in with chest pain again, their EKG may be abnormal from the first time you saw them, and so this time it becomes much more difficult to determine if something new is happening because if they have an abnormal EKG to begin with, when you see them again, it's harder to interpret whether there's new changes or not. So the EKG is very important. We do look at the chest x-ray, and then we look at laboratory studies. So we look at the blood draw. And so one of the things that's very common nowadays is something that we call cardiac markers or cardiac enzymes. So the heart muscle is very unique. There are special enzymes within the heart that are found nowhere else in the body. The muscle heart is different from skeletal muscle or smooth muscle, and the enzymes that are within the heart muscle are different from those type of muscles than the enzymes in those other types of muscles. So what we look for is we draw cardiac markers or enzymes, and we should never see any of these enzymes in a patient's blood system. The only way these enzymes make it into the blood system means that there's been cell death, that the cell has just ruptured and has leaked these enzymes out into the bloodstream. So as you can imagine, if you're having cell death in the heart, you're having a heart attack. So we do check these enzymes, and they are really specific for the heart. They have a specificity for the heart that's approaching 100%. They're like 99% specific to the heart. So if you see them, and the ones that we use nowadays are things called troponins. These are special enzymes within the heart. They're very specific to the heart. So if you see a patient, and even if they look fine, they're not having many symptoms, and you do, the EKG may look great, but you check their cardiac enzymes and their troponin is elevated, that tells you there's something going on, because you should never see that elevated. For the most part, there's some rare instances, but you should not see that. So the cardiac markers is a big deal nowadays. We did not have very In the past, when I first started, we had cardiac markers that were not specific to the heart. They were specific to muscles. And so if someone had been out the day before and had ran a couple of miles, you could actually make these markers elevated from skeletal muscle. Now, over time, we've gotten to the point where we can isolate enzymes that are only from the heart. So they're very specific now, and they're much more helpful.
Ask a quick question.
Yes?
How fast can you get that result? Is it within hours or minutes? Or?
So we can do, probably within the last 2 years, we are now doing what's called point-of-care testing. We can walk around with a little machine in the emergency room, and we can do a blood draw, put it in the machine, and you can get the results back within 5 to 10 minutes. Previously, before we had these little small handheld machines, you'd have to wait. Yes?
So it doesn't have to be an ABG?
Yeah, you can just do a venous draw, and they can put it into the machine at the emergency room here at this hospital and the emergency room in New Braunfels. They have them. They're point-of-care testing. They're a small little handheld machine. You can have the nurse go in there, draw the blood, and she puts it in there, and it takes 5 to 10 minutes, and you'll get the results right then and there. You don't.
I used to use y'all would do, because I used to work out over on the cardiologist for many years ago, but you have to do ABGs to get some.
Yeah, now you don't have to do any of that. And even after that, if you wanted these cardiac enzymes, you would have to send them down to the big lab where they've got the big machines, and it would take an hour, a minimum of an hour to get them back. And now we have these point-of-care testing 5 to 10 minutes. It's really made a huge impact. You can imagine, if you have a patient that, you're not sure whether they're having a heart attack, and sometimes that happens, it's a diabetic that says he's not having any chest discomfort, but he's not feeling right, very fatigued, short of breath. You do an EKG. The EKG is abnormal from previous. So you're not sure what's going on, so sometimes you do rely on those cardiac enzymes. And waiting an hour while someone's actively having a heart attack, that's not a good thing for the patient. So it's fantastic. So what we call all these patients that come in and we see them acutely for chest pain, they fall into this general category of what we call acute coronary syndrome. Acute coronary syndrome is a big catchment for any type of chest pain. And it can be someone that has chest pain all the way to someone that's having a heart attack. And there are different types of heart attacks, and different types of heart attacks are treated differently. And I'll sort of go through that in this next couple of slides. So we look at, this acute coronary syndrome. But I think the point of this slide is that when, after you've talked to the patient and you tried to determine what are their chances of having heart disease, you looked at the risk factors, you've done a physical exam, then you have to come up with sort of a differential diagnosis, because not everyone that comes in with chest pain is going to have a heart attack or heart disease. There are other things that can cause it, like I had mentioned previously. These are some of the things. I just listed some simple things. Of course, as a cardiologist, I'm always thinking it's the heart, so acute coronary syndrome. But you can also have a dissection of your aorta. So if you have an aortic aneurysm and it ruptures or it dissects, it will cause severe chest pain, and it can mimic signs of a heart attack. And that's fatal. So if you don't find that or diagnose it in time, your patient's probably not going to survive. So that's why it's listed up at the top. So folks that are actively having a heart attack, you have to get a handle on immediately and treat immediately. Aortic dissection is another thing that you have to immediately treat. One of the other things that I didn't put on here that can also cause very similar symptoms as a heart attack, shortness of breath, chest discomfort, even EKG changes, is a blood clot that goes to the lungs. So when we see someone in the emergency room and they're looking, acutely ill, the three things that we always look for is, is it a heart attack? Is it a dissection? Is it a blood clot to the lungs? Those three things are immediate killers. So you cannot miss those things. And so you have to make sure that you always have them at the top of your differential on, what are the chances this patient has this? If they do have it, I need to treat it immediately. So those three things, heart attack, aortic dissection, pulmonary embolus or blood clot to the lungs, those things are always at the top because they're lethal. And then as you get further down, these things, you have more time to work on. Is it chest wall pain, reproducible, esophageal spasm? The esophagus is a muscle, and you can get cramps or spasms in there, and they are horrible. Patients come in severe pain with those, and they're bent over, they're in tears, and if you don't know what you're looking at, you think they're having a large heart attack. And so esophageal spasm can really confuse you. Acid reflux, which is called GERD, gallbladder disease. Sometimes, since your gallbladder sits up high, can have some radiated pain up into the chest. You can get that confused at times. Other things, pericarditis and myocarditis, that's inflammation of the heart, but not a true heart attack. Around the heart, you have a lining around the heart that produces lubrication so that, as you can imagine, as your heart's beating 60, 70 times a minute, it'd be nice to have some lubricant on there so that not too much friction is starting. But that lining of the heart can get inflamed like anything else, and a lot of times it's usually a virus, like a simple cold virus that you get, then goes from the mucus lining in your nostrils and your oral pharynx down to the heart, and you can get inflammation around the heart. Not a heart attack, causes pain, but definitely not a heart attack, and that can mimic it, and you can get pericarditis or myocarditis. And then pleuritic chest pain is just the lining around the lungs get inflamed and causes it. And then there's rheumatic stuff that has to do with the musculoskeletal, and then psychogenic. Some folks just, they can sometimes, we've got patients that can just feel their heart beating. Most of us, we're usually too busy throughout the day to really put time into like feeling our heart or even hearing our heartbeat. Most of us could probably do it. Usually if you're going to be able to get that in tune with your body, it's usually at night, right as you're getting ready to lay down and the lights are off, TV's off, everything's nice and quiet. Sometimes you can actually feel your heart beating or hear it. There's some folks that can just feel their heart beating all the time, and they think they're having a heart attack, and so they're always in the emergency room and coming to your office. There's really not a lot that you can do. They have a normal heart, you test them, and everything's normal. They're just very in tune to their body. I don't know if that's a good thing or bad thing. And then, so we estimate the pretest probability of disease, and this is sort of where people fall into. They have a high pretest, intermediate, or low. Well, if they're intermediate, if they're low, there's not a lot that you have to do. If someone comes in, they're young, they're in their 20s, they're healthy, you can reproduce their pain, that's low risk. Those folks, you can tell them, hey, look, go take some Motrin for a couple of days. I'll see you back in a week. Let's see if it gets better. You don't really have to do anything for that. That's just reassurance. And so for low risk, you don't have to do anything. That's usually non-cardiac. The high risk, those are folks with positive cardiac enzymes, clearly abnormal EKGs. Those folks are high risk. Again, that's a very easy group to treat because you clearly know that they have heart disease and you need to start a treatment for them immediately. The problem with seeing a patient with chest pain is most patients fall into the middle, intermediate. They have some risk factors for heart disease. They may be diabetic, but the way they describe their symptoms are sort of atypical. There's no EKG changes. Their cardiac markers are normal. And so it's not a clear picture one way or the other, but they have enough risk factors that it could be heart disease. So they fall into the intermediate category. And that's where probably 80% of your patients fall into. And that's when you have to determine, based when they're in the intermediate category, what are you going to do for them? And so I always put these in because these are always fun to look at. And so one of the things that we look at is the EKG. And so what we do with the EKG is we look at changes in it, and this is someone that's having a heart attack. So when we look at it, it's a 12-lead EKG, so there's 12 leads, and they're all numbered, and they're in different areas of the body. So V1 through V6 is what we call the precordial leads. Those are the ones that go across your chest right here. The ones on this side, 1, 2, 3, AVR, AVL, AVF, are we call the limb leads. Those are the ones we put on your arms and your legs and on your abdomen, and those are your limb leads. Now, each section of the EKG corresponds to a different part of the heart, specifically a different part of the circulation of the heart. On the heart, there are really three main blood vessels. You have a blood vessel that goes down the front of the heart that we call the left anterior descending artery. We got an artery that runs to the back of the heart that's called the right coronary artery, and then there's one that sort of feeds the sides of the heart, and that's called the left circumflex artery. And different leads correspond to those specific arteries. So leads 2, 3, and AVF are your inferior leads. So in this patient, we see this part right here is elevated above normal, and this person is having an inferior or right coronary artery heart attack. And so you can actually use the EKG to not just tell you someone's having a heart attack, but localize which artery the heart attack's occurring in. And so the EKG, in some instances, is very helpful. I put a couple of others on here. And so in this one, we see some changes here, or elevations in these leads here, starting V1, V2, V3, and V4. And those are anterior leads. And so someone that has changes in these are having a heart attack in the front part of their heart, or the left anterior descending artery. This is not very clear. And this one here, I put this in because this is sort of a trick to sort of tell you that the EKG is not always as reliable as you'd like. And in this particular one, when I look at it, I see that there's changes or ST elevation sort of through all the leads. And so it's unusual for someone to have a heart attack in multiple arteries at one time. So if you see changes in all the leads, you have to ask yourself, well, what can cause that? And there's really one diagnosis that's sort of goes along with having chest discomfort and having elevation in multiple vascular distributions. That's pericarditis. So if someone has inflammation of the lining around the heart, you can imagine the whole heart is going to be inflamed, and you would see EKG changes everywhere. And so if you see EKG changes everywhere throughout the entire EKG, they didn't block all three of their arteries. They're having irritation to the whole heart, and that causes this type of pattern, and that's pericarditis. And so the treatment for pericarditis is much, much different than if someone that's having a heart attack. Yeah?
You also with this give a friction rub?
You can, yes. Yes. So, like I said, the lining around the heart produces lubrication so that, when the heart's beating, everything's nice and smooth. If the lining of the heart is inflamed, a lot of times it doesn't produce as much lubrication as you'd want, and as the heart is beating, it's rubbing or scratching up against that lining, and you can actually hear we call a friction rub. You can hear like a scratching sound, and it's that scratching that irritates the heart, and that's why you see the EKG changes. And then this is another type of EKG that we can see in a heart patient that doesn't help us. So there's a finding on an EKG called a left bundle branch block, which is an electrical problem within the heart. And it makes the EKG uninterpretable. So if someone comes in with chest pain and they have a left bundle branch block, I can't determine whether they're having a heart attack or not, or where the heart attack might be coming from based on this type of EKG. It's such an abnormal EKG, it doesn't really help you out. So that's how come I put this one and the last one in, is sort of to give you an idea that you can't always depend on your EKG or even chemical markers. You sort of have to put together the whole puzzle within your head to figure out what you're going to do with the patient. And then this is just a normal EKG. And this is, for the most part, what you see in a lot of patients is a normal EKG. A lot of the folks that we see come in and they're having symptoms, and we call that sort of, we call that angina or angina, meaning that they're having problems with their heart, and it's sort of leading up to the heart attack. And so, when they are not having symptoms, but they've had chest pain recently, their EKG is going to be normal. And so that's the majority of the patients we see as a normal EKG. So I put some management strategies in. So if someone has a high pretest probability they break down into two different types of patients that are having heart attacks. And we break them down into two different classifications based on their EKG. Now, the ones that I showed you, the EKG earlier, they had what we call ST elevation. That's the more serious of the two different types of heart attack, is what we call a STEMI or ST elevation MI. And that's what this mnemonic stands for. And if someone has a STEMI, that takes top priority. That's what, you see people, taken immediately from the emergency room straight to the OR to have a procedure done. That's because they're having a STEMI. So everyone gets aspirin. Aspirin actually is one of the most cost-effective medications you can give any patient that you suspect has heart disease. It reduces heart attacks or decreases heart attack size by anywhere between 17 to 30%, and think how cheap it is of a medication. It's a penny a day when you count out how much it costs per day. It's one of the most cost-effective medications we have in all of medicine. But we always start with that, and then we look at how comfortable the patient is. Are they in cardiogenic shock or not? And then how do we transport them, getting them from your office to the hospital? Different things that you need to do. Making sure they have oxygen on. Sometimes we bring in the crash cart and get ready to have the pads around, thinking that we may have to shock this patient out of an arrhythmia. So there's a lot that goes on with someone with a STEMI. A non-STEMI is someone that's having a heart attack. Their chemical markers are elevated, but their EKG is pretty normal. And what we know with these type of folks is they're having a heart attack. It's usually a much smaller heart attack, and it's a precursor. If you did nothing for these patients, they would go from having a non-STEMI to a STEMI, the big serious one. And so these folks, they're urgent. You have to do something for them, but you don't have to necessarily go straight to the cath lab. Yeah.
I was going to ask you, cath lab, that's exactly what I was.
Yeah, so these folks that have a ST elevation MI, they go straight to the cath lab so we can go in there and open up their blocked artery. And we actually have time limits. The cardiologists throughout not just in the United States, but throughout the world have set, limitations. A patient, by the time they get to the emergency room, if they're having a ST elevation MI, from the time they present to the emergency room to the time you open up that blocked artery should only be 60 minutes. They should have an EKG within 10 minutes of showing up to the emergency room if they're complaining of chest pain. If you're transferring a patient from Seguin to New Braunfels or Seguin to San Antonio or Austin for a STEMI, they're supposed to make it to the next hospital and not only be there, but have that artery opened within 90 minutes. There's standards out there, and everyone is graded by these standards. That's another thing, and if you have got poor compliance with these numbers, your hospital can get shut down, or as a practitioner, they can cut away funding for you or something. So we're actually graded continuously on not just what you know, but the quality of medical care you provide. That's the big deal nowadays. Quality care. It's not so much, it's not so much what you know, but how do you deliver the medicine? Do you do it in a timely fashion, and the quality, and they look at outcomes. And so we're graded on this. You're timed on everything. So this is a big deal. And then, the folks, the high risk are the ones that are clearly having a heart attack, but these are the ones that, like I said, are 80%. And then our term is we have to risk stratify. They have enough risk factors that I'm worried that the chest pain they're having is potentially coming from their heart. So how do I prove it? It's not, I can't just say, hey, just because this patient is diabetic and smokes and has been having chest pain, I think that they have heart disease, so I'm going to start them on medications. You really need to prove that they either have heart disease or they don't. You can't really go on assumptions because you'll get burned. Medicine is not only a science, it's an art. And sometimes you can run tests on a patient and your tests come back saying everything looks good, but you still look at the patient and you calculate their pretest probability and you go, they're diabetic, they smoke, their pain sounds like it's heart disease. And you do the test and it looks fine, but you still have a high index of suspicion. So you may order another test, and then the second test proves that they have the heart disease. So that's where the art of medicine comes in. And so one of the things that we do is stress testing, exercise stress testing. And it's really a big deal. And so that's why whenever a patient comes in with chest pain, we always ask them about symptoms with exertion. Because one of the things that we're going to do is if they fall into this intermediate category is we're actually going to have them get on a treadmill and see if we can reproduce their chest pain or see if we can get EKG changes when they're having chest pain. As you can imagine, if you're just sitting there watching TV at night and you start getting chest pain and your heart's beating at 60 beats per minute and your blood pressure is nice and controlled, well then if it is really coming from your heart, when we get you on a treadmill and your heart's doing 160 and pounding and squeezing, you should absolutely have chest pain then. You should also have EKG changes. So that's why when you come see the heart doctor, we always, the first thing we want to do is do a stress test to see if you have heart disease. It's a very simple idea behind it is if you have symptoms at rest, then you should almost always have them with exertion. We should see something, symptoms or EKG changes. And so that's what we do. But there's different types of stress tests and different complexities of the stress test. So the basic one is just an exercise stress test that you just get on a treadmill, we hook you up to an EKG, and you start off at a walk, and then you go up to a jog or a run. And so that's the most common thing that we do. And it's our first line of testing. And we usually do these for fairly healthy folks that we might suspect have disease. And so as you imagine, you have to have the ability to exercise, which a lot of patients do not have the ability to get on a treadmill and get up to a fast walk or a jog because of their age. They may be 70 years old and they can do a good walk, but having them go any faster they just can't do. And there may be limitations, orthopedic limitations. They got a bad back, they've had hip fracture or something. So you have to determine that. But the main thing that we look at is doing stress tests with imaging. And this adds a level of complexity to the stress test. And most of us usually add some type of imaging to a stress test because it decreases our chances of false positives. So anytime you do a test, and it's any type of test you do, not in medicine, but almost any test you do, there's, you break it down to, false positives, false negatives, true positives, and so forth, true negatives. And, with any test, there's always going to be a chance that you have a false positive. And so by adding imaging, scanning of the heart during a stress test, you decrease the chance of having a false positive. So what you do is you improve your sensitivity and specificity of a test. And I'm sure as you get further along in your science classes, when you start to do some type of testing, you're always going to look to see how sensitive a test is and how specific a test is. And that sort of determines sometimes on how you're going to pick up a test or how you're going to order a test, because sometimes you want a test that's only specific for some type of disease and not another type of disease, or is sensitive in picking up everyone with a certain type of condition. And so you have to look at the sensitivity and specificity of a test, and those two things help determine what your false positives or false negatives are. And so most of us will add imaging to it, and the imaging comes in two different forms. One is adding an ultrasound to the stress test. So someone exercises and then we do an ultrasound of their heart as they're exercising so we can actually see their heart beating and squeezing. The other one is a nuclear stress test. So we give them a radioactive isotope that goes specifically to the heart. It's actually, the way it's designed is most of these radioisotopes are, they got like some type of potassium molecule attached to them, and the potassium is something that the heart loves, and so it sucks up this radioactive isotope to make the heart glow. So, as you can imagine, if you give this radioactive material when they're just sitting there and the heart glows and is just radiating everywhere, as they exercise, if there's a blocked artery, that area of the heart is not going to get as much blood flow. And so when you give them another dose of this radioactive material, that part of the heart won't glow as much. And so you look at the rest and stress images and see if there's part of the heart that doesn't look like it's glowing anymore. And that's how you can tell if someone's had a blocked artery or not. The thing is that these radioactive materials usually short-lived. They usually only have a half time of 6 hours. So you can actually do the test in one day, and if they want to go to the airport or travel the next day, they're not going to set off alarms. But that has happened. It'll be picked up. And then for folks that cannot get on a treadmill, we actually can do chemical stress testing or pharmacologic stress testing. And there's different ways of doing it. Most of us use this chemical called Lexiscan. It's a vasodilator. It dilates the arteries of the heart. And so you look for increased blood flow to the heart. The other way we can do it is using a medication called dobutamine, which is a continuous infusion. And what that does is it just speeds up your heart. It's like giving you adrenaline. And patients hate it because they're just sitting there. But as you give this infusion of dobutamine, their heart starts picking up. They start at a heart rate of 60, and then as you start the infusion, it goes up to, from 60 to 80 to 100 to 120 to 130, and they're sitting there and their heart's just pounding out of their chest. It's a very unusual feeling, and patients really do not like that medication. But it simulates the same thing as if you were on a treadmill and you got your heart rate up to 150, except we're giving you a medication that's doing it. And so these are different ways for folks that cannot get on a treadmill. Interestingly enough, if you are unable to get on a treadmill and exercise, you have a higher chance of having a heart attack down the road than if you can get on a treadmill, even if your study turns out to be normal. Sort of makes sense. If you can't exercise, you probably have a higher chance of getting diabetes or high blood pressure or high cholesterol, which then increases your risk for a heart attack. So having the inability to get on a treadmill is actually a predictor down the road of worse outcomes. So even though your test may look fine here, it just means that 15 years down the road you might have a problem. So who should not be stressed? Patients that are asymptomatic, low risk. Are they able to walk? Not. Let's see. If they're unstable, high-risk patients, we're not going to stress those. They're going to go straight to the cath lab. And folks that have alternative diagnosis and so forth, and other things too. This is a very important thing. Results will not alter the course of management. So this happens a lot. Family brings in a patient. The patient's in their late 80s. They really don't ambulate anymore. They're in a wheelchair or in bed. But when they do get up out of bed, they do have some chest pain or chest discomfort. And to me, it sounds like it's heart disease. Well, in those folks, if they're 89, I'm not going to do a stress test on them. I don't think it's inappropriate at that time in life, especially if someone is, basically not ambulating. At that point, I will presumptively assume that they have heart disease. And in those cases, I will start them on medications to protect their heart without doing a stress test, because I think that's a waste of resources at that stage in life. As we all get older, we get hardening of the arteries. This is something that I didn't really have on there for risk factors. So you may live a great life. You might run marathons. You might be a vegetarian. You may never smoke. If you live long enough, you're going to get heart disease. The cold hard facts are that once you get past your 40s, you're going to die of either one or two things. You're either going to have cancer or die, or you're going to have heart disease. Well, if you've made it into your 80s and you haven't had cancer, that means you're probably going to die from heart disease. It's either going to be a heart attack or a stroke. So, unfortunately, it's one of those two things statistically. You're at that age. I guess maybe you could have an automobile accident if you're still driving, but so your greatest risk factor as you get older is just your age. If you live long enough, you're going to get hardening of the arteries no matter what you did when you were younger. And so, once they get to a certain age, depending on their functional status. And then we have a lot of folks that complain of chest pain that are fairly demented. And so, the quality of life, you don't want to put someone at the end stage of life through a bunch of tests just to prove that they have heart disease. You'll just treat them presumptively at that age. So you have to look at, will ordering tests change the course of management? And sometimes it won't. And so you won't order tests. Then the folks with low pretest probability, you just sort of treat or refer out back to their primary care doctors and say, hey, I think it's some type of musculoskeletal problem. I put them on Motrin. Can you follow them up? And you give them reassurance. But this becomes a big problem. What about repeat presenters? So we have folks that, you don't think it's their heart. They're low risk, but they still continuously have have chest pain. And they're very worried about it. It's a fatal disease if you miss it. And so sometimes reassuring patients works the first time, and maybe even the second time. But if they come back to your office, a third or fourth time, at that point, even though you think that it's low risk and they do not have heart disease, at that point you're sort of obligated to reassure the patient that they don't have heart disease by usually doing some type of test. Patients, if they come to see me and they come for their third time and I really don't think it's heart disease, if I tell them that third time that, look, I don't think it's your heart, you don't smoke, you're young, you exercise all the time, I think this is something else, eventually they're going to go to someone else and someone else is going to do a stress test on them. So after a while, you're sort of obligated to prove to them that they don't have heart disease. And so that's what I have down here about these repeat presenters. And they can take up a lot of resources. You see them in your office, you tell them it's not chest pain or cardiac chest pain, and then 2 weeks later they have chest pain again, but this time they go to the emergency room and they're using up resources in the emergency room and they're getting a huge bill because they went to the emergency room. And so, if they're coming from your office to the emergency room, coming back and forth, they can use up a lot of resources. So even though you think they're low risk, sometimes you're obligated to do testing on them to prove that there's nothing wrong, which is unfortunate, but you have to do it. Definitive management for this STEMI, this is the bad type of heart attack. We take them straight to the cath lab. We used to give them medications that would bust up the blood clot, but we really don't do that anymore. And then we have all these new cool medications that we have to give, aspirin, Plavix, the new improved Plavix, and then cholesterol medications, beta blocker, ACE inhibitors. I mentioned before, about it's not just what you know, but the way you deliver medicine, your quality of medicine. And I talked about being graded on how quickly you take care of a patient. You're also graded on, are you putting the patients on the correct medications after they have a heart attack. So if someone has a heart attack and they leave the hospital and you don't put them on aspirin, you can get in a lot of trouble. If you don't put them on, a cholesterol medication or a beta blocker, or ACE inhibitor, which all of these medications have been shown to reduce your chance of having a second heart attack. If you don't put these patients on these medications and you show a trend of not doing that, you'll get in trouble with the Texas Medical Board and they can suspend your license. So, you are graded continuously. So, the whole thing about this, it's a journey, it doesn't end when you're finished with your training. Someone's always looking over your shoulder to make sure you're doing the right thing and you get graded on it. And, if this is all you've ever done and you start making mistakes and they take your medical license away, it's hard to start over at a certain age. Yes?
So do y'all not do angioplasties anymore, where you go in and do the balloon and then scrape the...
No, almost everyone gets stents now. Using a balloon to go in when an artery is blocked, when someone's having a heart attack, is really not the standard of care anymore. We used to, long time ago before we had stents, if someone had a heart attack and they had a blocked artery, we would go in with a collapsed balloon, and then we'd inflate the balloon and it would push all the cholesterol and the clot to the sides and it would reopen the artery. But nowadays we use stents, which are like metal mesh that is collapsed on a balloon, and then you inflate the balloon and it spreads the mesh open and it props open the artery. What we know is that if you just do a balloon and nothing else, those arteries close up again in a short period of time. They close up, within a couple of years, the chance of them closing up is between 50 to 70%, which is very, very high. If you put a stent in, you reduce that 50% down to 20%. And now we have stents that have got drugs on them. They got chemotherapy drugs on there that prevents the cells from growing in that area, so there's less chance of having a blockage in that same area. And you decrease it from 20% with a regular bare metal stent to about 5 to 10%. So our technology is getting better. And so we don't do just balloons anymore. And then these folks here, these are very similar to these folks are the ones that are having a heart attack, but it's not the very severe one. These folks, a lot of times, will do a cool down period, meaning we'll give medications to try to calm the heart down. And then within 24 to 48 hours, then we'll take them into the cath lab to see what the arteries look like. But these are usually the ones that we don't have to rush into. And there's a whole bunch of different ways to determine these folks that have unstable angina or non-ST elevation MIs. Within this group, you can actually further break them down to determine which of these groups are higher risk and which should go within 24 hours, which needs to go within 48 hours. So there's all different ways to block them down, and you have to grade everyone and determine what's the best approach. And again, you're graded on what kind of medications you use. And then the different types of stents, bare metal stents and drug-eluting stents. These are the big things. Mostly everyone gets a drug-eluting stent. That's the standard of care nowadays. Bare metal stents we still use, but we have to have the right physiology in order to do it or put them in, just because they have a higher risk of getting what's called restenosis. They block off again. And then depending on the setting and the type of stent you put in determines how long you put someone on. Well, aspirin is indefinitely all the time. But this Plavix, which is another medication that works at the platelet level from causing clots. The problem with Plavix is that patients don't mind taking it. It's a once-a-day pill. It's just that it's very expensive, and can be anywhere between $100 to $200 a month for the medication. And when you're talking about retirees that are on a fixed income, paying $200 a month for medication is it's outlandish for some of them. And so that becomes a big deal on how long you have to keep them on the medication. And then long-term management, secondary prevention, that's the big key nowadays is, as you can imagine, if you've had heart disease once, you can get it a second time. So the big thing we look at after someone's had a cardiac event is reducing the risk of having a second one. And you reduce risk for recurrent episodes. And I think, the thing to point out, because patients come back and they go, after I had my heart attack, I changed everything I've been doing. I eat better, I lost weight, I exercise, I take all the medications you gave me, and I still had another heart attack, 7 years later. Why is that? The medication's not working. No, what happens is, you reduce the risk. The risk for heart disease never goes to zero. There's no such thing as zero risk in medicine. What you do is if someone's had a heart attack, if you put them on no treatment, it's 100% that they're going to have a second event. So by putting them on the appropriate medications and them doing appropriate lifestyle changes, exercising, stop smoking, what they do is they reduce the risk from off the charts to the risk of what the general population is. And so, I think sometimes patients forget that there's no such thing as zero risk. Once you've had heart disease and if you do everything by the book, you're still at risk for having another event down the road. And so they come back very surprised thinking, why have I been taking this medication for 5 years and exercising if I was going to have another heart attack? And you try to tell them, well, at least it's 5 years. You'd have had it in 6 months if you didn't do anything. So I think that's something that we really have to point out is that secondary prevention means that we reduce your risk. Your risk does not go to zero. And then we do additional things like cardiac rehab. We have here in Seguin, at the hospital here, we have a fantastic facility for cardiac rehab. It's actually one of the best I've seen. It's a brand new facility. And what cardiac rehab is, it gets patients in that have had open heart surgery or have had a heart attack, and they get in there and they start an exercise program. And it's not only an exercise program for the patient to start to become more active, but it gives patient confidence in starting to become more active. After you've had open heart surgery, patients are scared that if they try to do any type of activity, they're going to have another heart attack or their chest is going to come open from having it filleted in two. And so it really offers confidence for the patient. And cardiac rehab is a must for any cardiac patient that's had a heart attack or bypass surgery. They really do need to go. It's a 12-week program. They go 3 times a week for at least an hour, and it's monitored, and it's just a fantastic program. It really is. It gives a lot of patients confidence. And what we see is the continuation. Even though it's for 12 weeks, what we see is about 50% of the patients end up signing up for the gym and staying and then continuing exercising. So it actually does work. So that's a big deal. And then patients need regular follow-up and testing. Currently, right now, if you've had a heart attack or have had bypass surgery, you are supposed to have periodic testing. It's usually about once every 2 years you get another stress test just to make sure that everything looks fine. Bypass surgery is not a cure. What we know is with these bypass grafts, after about 5 years, they start to have problems. They go down. We can put these bypass grafts in to the heart, but we can't make them last forever. And some folks, they do last a long time, but we know at 5 years, they start to go down. By 10 years, 50% of the bypass grafts have closed off. So you have to have periodic testing because a lot of times when these grafts go down, it's not a catastrophe. Patients don't come in with a heart attack. They have very subtle symptoms, so you have to do continuous follow-up and screening. Then, of course, the big thing is lifestyle changes, losing weight, watching your diet, quitting smoking. If you're diabetic, getting your blood sugars under control. And that's all I had.
We have time for a few questions for Dr. Garcia, and then a chemistry seminar right afterwards with Nate about the speaker. Right, Nate?
Do you do the actual cardiac test? Are you doing that?
Yeah, I do them, but not here at this hospital. This hospital is opening up a cath lab. It'll be open in about a month at the end of April. And once they open it, I'll be doing cardiac caths here. I usually take my patients to the New Braunfels Hospital to do them. Yes.
Where do you see the future? That was an elegant presentation, the age of element medicine, which you guys have available. I read an article in Circulation Research maybe 5-8 years ago about stem cell replacement in some work out of Brazil in rabbits. They myocardial infarct
Yes.
rabbit, and then they took some stem cells and they created a certain amount of regrowth.
Yes.
Where's that at?
Well, they're actually doing that in select centers in the United States. So, yes, in humans, yes, they're actually doing that. So we have folks that have had such big heart attacks that their heart function is so poor that they're basically in the hospital continuously. They can't get up and do anything. Their heart function is so poor. So at select centers like Johns Hopkins, Cleveland Clinic, Mayo, places like that, they're doing that. And it's very sophisticated. It's not just stem cells. They can actually attach certain parts of the genes sometimes onto a virus and then inject the virus into the heart cells, and then that stimulates the heart cells to grow. And with the virus, you have the DNA that you want on there, and it's just very sophisticated. They're using all kinds of stuff. And sometimes they're just using plain old stem cells to do it, but the way they get around that sometimes is using viruses, because we know the viruses invade the cells and usually then cause multiplication of the virus, and so you can generate a bunch of DNA in the heart tissue with the virus. So yeah, they are doing that. Now, we measure the squeeze of the heart, how well the heart is squeezing. We call it the ejection fraction, how well it's squeezing, pushing blood forward. And some of these folks, a normal ejection fraction is about 65%. Some of these folks have got ejection fractions of 5%, meaning their heart's just barely moving. And when they do these stem cell stuff, they don't come back to normal. They go from 5% to 15%, which statistically is a huge improvement, but maybe clinically not fantastic. So we still got a ways to go with that. Yes?
You mentioned like on the other side of cardiac risk factors, in patients with dextrocardia, is it like more serious and more prevalent?
No, so that's a good question. So you can have, that's a congenital defect where the heart is on the opposite side of the body, and it can throw you off. And there's two different types. You can have just the heart on your right side of your chest, or you can have your heart on the right side of the chest and everything in your abdomen. So your liver being on the right side is now on the left, the stomach is from the left is now on the right. And just because you have that doesn't increase your risk for having heart disease. It would still be based on your risk factors. So we have folks that have that. I saw a patient here in New Braunfels that was 70-something years old and was coming in for cardiology screening and never knew that they had dextrocardia until they came in at age 70-something. So you can lead a completely normal life and not have any problems at all. It doesn't increase your risk necessarily, unless there's some other type of congenital defect associated with it. So, yes?
In patients with the pericarditis, is like their reoccurrence like similar to like the increased level of like, risk as like heart attacks and stuff like that, or is it a different?
Once you have pericarditis once, you are more likely to get it. We have folks that get recurrent episodes of pericarditis. So every winter, if they get a really bad cold or bad flu season, they can get reoccurrences of pericarditis. Yes, and sometimes pericarditis can last for weeks, and it's just a constant pain in the chest. And we try anti-inflammatories, and sometimes we go so far as putting people on steroids for sometimes weeks and months at a time, so the inflammation will go down. So even though it's a benign disease, it has a significant impact in your lifestyle because you're usually very uncomfortable. So, yes.
Will you discuss the correlation between the TIA or heart attack?
Yeah, well, a TIA is like a mini stroke. So it's a stroke that sort of resolves within 24 hours. And so as you can imagine, most strokes or TIAs originate from blocked arteries. The most common type of TIA or stroke originates from the neck arteries. So your carotid arteries start to build up with cholesterol, and you get cholesterol plaque in there. And then what happens is the blood is constantly moving across those cholesterol plaques. You tear a piece of that cholesterol plaque off, and that cholesterol goes up north, and then it blocks an artery, and then you end up with a small TIA or stroke. So that's one way that you can have a stroke. The other way is just the arteries within the brain start to build up with cholesterol, and you have one that way. So whenever someone has a TIA or stroke, the first thing we do is we always scan their neck to see if they've got blocked arteries and how bad. If they've got 50% or more and they've had a TIA or stroke, we will go in there and scrape out all that cholesterol because their chance of having another stroke is extremely high. So, and then we get back to the point that if we find someone that's had a stroke, and we take a look at their neck arteries and they're blocked, then we know they have about a 70% chance of having heart disease too. So they all come around full circle. So, yes, sir.
What's the current thinking, since we're talking about bifurcation,
Yeah.
what's the current thinking, endarterectomy or EPCA?
No, so what up in the neck, it's still the best way to clear out the neck is with surgery, to go in there and open it up and do a carotid endarterectomy instead of a stent. There's been a lot of trials looking at comparing surgery to putting a stent up in the carotid arteries. As you can imagine, surgery is much more invasive. A patient has to stay overnight in the hospital. They have a wound that has to heal, chances of infection. The problem with putting a stent, even though it's much less invasive and the patient could technically go home, maybe even that day, is that the higher risk for stroke is that when they do the surgical part, they can like clamp off above where they're operating, so that as they're scraping stuff out, no debris goes up to the brain. When you're doing a stent and you're doing the stent from the leg going up there, you can't clamp off the artery. So as you're inflating the stent, if there's any debris that gets free, it's going to go up to the brain and you're going to end up with a stroke. So it's a higher risk of stroke. So it's technically not the preferred way to clean out the arteries in the neck.
At this point, we're going to call it quits for the questions, and I do want to thank Dr. Garcia. You got to go to the hospital next.
Students at TLU engage in high-impact educational experiences that include civic engagement, aesthetic expression, critical thinking, and a focus on intercultural knowledge in a community that welcomes the interplay of faith and reason.